Thanks so much, Jesse and Marissa, for inviting me to participate in this very important panel. Excuse me. I'm going to be discussing the role of enucleation in 2017 and beyond, and really specifically define how we use enucleation today. I'd like to introduce my esteemed co-panelists here, Stephen Haddad, who works with me in Los Angeles, and Greg Dootz from Michigan. And Brenda Galley also will be participating in this panel as well. Is there a controller? So I'm going to begin by just reminding everyone that enucleation remains the most commonly utilized modality for retinoblastoma worldwide. And fortunately, we've been reducing the number of enucleations being performed in the US, but worldwide it's still the most common and important modality that we have to cure retinoblastoma. And also, it's still the most effective way of curing children with retinoblastoma if our goal is to cure the body, cure the child overall from the cancer. It's a relatively pain-free procedure. It takes about an hour. It's performed usually as an outpatient procedure. The prosthesis is fitted 1 month later. And especially for unilateral patients, the visual prognosis usually is unchanged because most of the time, especially with unilaterals, the visual prognosis is quite poor. Usually the tumor is quite advanced and has taken away vision. So really our consequences are cosmetic, psychological, emotional, and social. Again, these are mainly the points I want to make for unilateral patients. These are very important consequences, obviously, but from a visual standpoint, usually the child is not affected significantly. So how do we use enucleation in 2017? We use it for advanced disease diagnosis. So this is for primary treatment failure, also for secondary treatment failure for persistent RD, loss of fundus view is very important, and also a painful eye. How will enucleation's role change in the future? Well, we talked a little bit about more effective screening programs, perhaps more effective primary treatment options, and safer secondary treatment options, such as intravitreal melphalan. So at this point, I'd like to open it up to the panel and talk about reconstruction. And I'd like to begin by asking about these newer modalities such as LCD screens. Stephen, do you want to talk about that?
Sure. There's a digital process that's out there for an ocular prosthesis, mostly used for iris reproduction. It's still in a developmental stage. It's somewhat flat-looking and doesn't have quite the depth that the painted prosthesis has at this point in time. I haven't seen the LCD screens used on the spectacles that they're trying to develop at this point in time. I haven't seen any patients with that here in the US at this point in time.
Do you think it has a viable role in the future?
I think it would have a viable role if it can be on the same plane as the remaining eye, as the good eye. There's something about an LCD screen that doesn't quite give the same appearance as even an acrylic model, which is inside the body. So it has its challenges.
Just to give a little background on the idea of the LCD screen, when I was working with David Abramson in 2006, he actually had an idea for this project and had supported someone at Sloan Kettering to work on the project. I don't think anything viable has come out of it. And then more recently, Jeremiah Tao at UC Irvine has been working on the project as well. Brian, you have a few comments on that?
Well, yeah, actually, I can follow up because I'm still involved with that process. And we have a patent on the. We've still been developing it, and one of the biggest hang-ups is getting a non-reflective, non-illuminative, curved visual screen, because we wanted to have that depth and realism of the screen. And that technology is available, and we're incorporating it into the model. But we're still working on that project, and it's an interesting one. I know there's some other ones that are coming out as well, but that one's still up and going.
Great. I do want to back up a little bit and talk a little bit about the differences between centers. I think right now across the U.S. there are major differences in how enucleation is used at different centers, and they center around two major groups of patients. One is advanced diagnosis, or advanced disease diagnosis, especially for unilateral patients. So for example, a group D or group E patient presents unilateral. At many centers, the majority of those patients will get treated. I think at Brian's former center at Sloan Kettering, most of those patients get treated. At many centers, like at our center, we discuss with the parents a lot about the utility of trying to save an eye that doesn't have great vision, what metastatic risk that might mean for the child. And so at many centers, advanced disease at diagnosis, especially if it's in one eye, often will get enucleated. Secondly, what happens after the primary treatment fails? So for example, if the intra-arterial chemotherapy fails, often at some centers they will offer repeated treatment with more chemotherapy options, so multiple drugs, higher doses, and then if the patient has received primary systemic, then the decision might be to go ahead and treat with a different modality such as intra-arterial. At our center, if the patient has unilateral disease and the visual prognosis is quite poor, we might advise the parent to consider enucleation. I think we certainly offer the option at our center of trying different things, but often we're advising enucleation because to go through these different modalities, which have more morbidity for an eye that doesn't have great visual potential, we don't think in many situations that's advisable. I know at some centers they are quite aggressive in trying to save the eye with doing different things. So that's where the major differences lie. Brian, you want to talk about what your approach is for treating an eye that's failed primary therapy?
So it depends on, so my treatment feelings are, it depends on the state of the other eye and the vision for what you do if you have a recurrent retinoblastoma in one eye. And so if it's the patient's only seeing eye, then we will do everything we can to try to save some amount of vision in that eye. Whether, we have a big experience with intra-arterial chemotherapy because we've used that pretty much for everything from where I used to work. And, we were able to save probably on second go around with that up to 40, 50, almost 60% of the eyes on the recurrent end. So I think there's viable options in desperation, but I mean, one of the examples is one of my co-residents' daughter had retinoblastoma, and I counseled him to have the eye removed. So there's certain situations where, all the technology and all the ability to save an eye is probably not going to make a huge difference in the outcome, as you said, and it's safer for everyone and simpler to remove an eye. So I think it still has a really viable point. But again, on the other extreme, there's a lot of technology and a lot of things that we've can do to save an eye if we have to.
Brenda, what's your perspective on these two categories of patients?
I think for unilateral, the only eyes we should try to save are those that have a clear possibility of having useful vision and clear vision of the optic nerve not threatened. Other than that, they should be removed by enucleation. And the other thing that we haven't commented on here yet is the cost. Not the dollar cost, but the cost to the whole family of trying to save an eye, which is intensive treatments at each session, each visit is costly in many ways, direct and indirect, and but especially the cost to the child of all those efforts. When taking the eye out, the child goes back to school. Those critical years of a child's life are when the child should be playing. Their job is to play, as you can see in Morgan's room. If you deprive them of that because you put them under all these treatments, they're always in hospital, they're always getting another treatment to save an eye, you're not doing them a very good service.
Yeah, that's an excellent point. Often we'll save the child multiple anesthesia sessions during those very important years. Another thing I want to remind the parents about is that when you're discussing these treatment options with the physician, it is always your right to bring up the possibility of enucleation. I think the only situation where I wouldn't consider that possibility would be if I can treat a tumor with focal modalities like laser or cryotherapy, but if I'm considering more systemic chemo, or if I'm considering intra-arterial or even intravitreal injection, the parents always have the right to bring up the topic of enucleation as a viable option. A common story that I hear in some of these bad outcome cases is that the parents tell me, or I read in the notes that the enucleation was never discussed when they were considering these other modalities. And as a parent, it's always your right to consider enucleation if you're considering some of these other riskier modalities. Okay, so let's talk a little bit more about how to reduce enucleations, because as we talked about, even though it's a great treatment, there are definitely negative consequences to enucleation. And as I discussed, these are the three strategies that we have. And we talked a little bit about the screening programs, and unfortunately, it's a difficult problem to solve because retinoblastoma is such a rare cancer. 1 in 18,000 babies will develop this cancer. And to diagnose it earlier, often we'll have to do dilated fundus exams, which is really not feasible. And we talked about awareness, which is very important. What we really need is a very safe, non-invasive imaging modality that we can do in all children, or possibly genetic testing early on that might help screening. More effective primary treatment options. There's no doubt that intra-arterial chemotherapy has led to fewer enucleations in the US. Over the last 10 years, we're doing fewer enucleations because of intra-arterial, there's no doubt about that. However, on the flip side, I think we've had a few more metastatic cases. It's not really discussed very often. We've had a lot of debate at our scientific meetings about whether intra-arterial has led to more cases of metastasis. And if you look at the studies, it really hasn't been proven per se. It's a difficult thing to prove because the incidence rates are pretty low. But I'm convinced that the metastatic rate is slightly higher with intra-arterial. Brenda, do you want to touch on this topic? It's very controversial.
I think the problem is that many of the papers on intra-arterial chemotherapy are very hard to interpret because every patient isn't designated. You don't know what happened to every patient. For example, the loss to follow-up rate, that's not part of the papers. So then you don't know where those children are. And so the ones that, and we know from the social media that there are children around the world who've had intra-arterial chemotherapy who have died but aren't counted in the papers because they're somewhere else. So it's a big, big problem and we need better data.
And then the final category, the safer secondary treatment options, I think this has been a big revolution in our field. For example, intravitreal chemotherapy is much safer than radiation. So for patients that have developed seeding after the primary modality, we used to either enucleate them or we used to perform radiation. And radiation wasn't a very attractive option, but now we have intravitreal chemotherapy, which appears to be safe in terms of tumor spread outside the eye. We're seeing a few cases of retinal toxicity, but it's really led to a lot more eyes being saved after the primary modality has failed. So those are the main strategies that we're working on. So I think at this point, we'll move a little bit to reconstruction. And I do have a presentation on reconstruction, if we can just put up my second talk here. So this is a talk that I gave recently to an oculoplastic audience at our center, but I did want to discuss a few of the reconstructive options that children who've been enucleated have. And it really comes down to these categories. We see cases of socket contracture, and that's when the soft tissues around the implant contract for various reasons, maybe from radiation, maybe from previous surgery. Poor orbital volume, maybe the implant that was placed was too small, or they have a dermis fat graft that's too small, or the implant has extruded or become infected, and then finally poor prosthesis motility. So the primary treatment option that we have for socket contracture is to perform a mucous membrane graft. And here's a patient who had retinoblastoma many years ago and had radiation, had severe contracture, and the implant was really falling out because the soft tissues around the prosthesis had contracted. There really wasn't enough room for the prosthesis to remain in place. So we performed a buccal mucosa graft from inside the cheek several times and was able to retain the prosthesis. That's the main option that we have for socket contracture. A dermis fat graft also provides some mucosal membrane surface, but its main purpose is to provide some orbital volume and provide support for the prosthesis. And orbital volume is a big problem because often these kids are very young when they have the enucleation. We can't fit an adult-size implant, and so there's a volume problem. So the prosthesis ends up being very thick, and these thick prostheses have issues such as poor motility. And our options for adding volume would be either to replace the implant with something bigger or to perform a dermis fat graft. They both work well, kind of depends on the situation. Here's a series of surgical photos showing how a dermis fat graft is done. Parents often ask me, how is this done? Is it safe? It is perfectly safe. However, there is a scar here. What we do is we basically just take off the surface layer of the skin, and then this is the dermis underneath, and we excise that or remove that with a little bit of fat attached to it. And then we close this, and this forms an incision scar about 1 inch long. And then we take the fat graft, put it in the socket, and then we suture it to the edges of the conjunctiva here. And this really provides a lot of orbital volume, a little bit of mucosal membrane augmentation as well. A third problem that we find commonly is exposure of the implant. You can see there's a very small implant exposure here, and this is much more common with the porous implants, so MedPor or hydroxyapatite implants, which are touted to have increased cosmetic results, increased motility. That really hasn't been proven, but they're very popular. I think that the main advantage of them is that they don't migrate as the solid implants do, and they do offer the option of implant pegging later on. And the clinical signs of exposure would be increasing erythema, discharge, anything other than the baseline symptoms that a patient might have. You have to be aware that the patient might have an exposure problem. And there are lots of things in our patients with retinoblastoma that predispose to this complication. The main one is that we're trying to fit a very large implant into a very small orbit. And there are also concurrent treatments that are going on, like chemotherapy or radiation, all things that hinder vascularization of the implant, which can then lead to the exposure problem. And there are different types of treatments that we can offer for the exposure, but I have to admit, in the vast majority of cases, we have to take the implant out, which is not an easy procedure. You have to basically dissect the implant out. It's one of my least favorite procedures to do. There's quite a bit of bleeding involved. Patients do well, but you're basically starting over with the socket, which is never a good thing. There are some cases where I can save the implant by shaving the surface layer of the implant, but for the most part, these get infected and have to be replaced. And then finally, poor prosthesis motility or movement, and this is a major issue for our patients, especially when they get into their teenage years. They become much more aware of their appearance, social interactions, and I take care of a large group of adolescent patients who have been enucleated, and this is a common complaint that they have. And I was speaking at an Ocularist convention. I think Stephen might have been there, but I was rather shocked that when I asked the audience to indicate whether they like doing these fittings with after pegging, and most of them said no. And I work with Stephen quite often, and he doesn't mind doing them, and I think a lot of our patients benefit from them, but there's really a lot of thinking out there among the ocularists that these are very difficult to fit. They cause problems with a clicking sound, maybe poor fit. But there's just a lot of work involved in getting a patient fitted properly after a pegging, and that's maybe the reason why they're not very popular. But the patients really love them. And here's a patient who had the pegging done. The procedure itself to put the peg in is very straightforward. I just drill a small hole into the implant and put this peg in, and then the ocularist will fit the patient. And there's a lot of benefits. There's a dramatic increase often. There's almost no rotation. There's better projection of the prosthesis and less weight on the lower lid. And there are some disadvantages. There's a bit more mucus from the socket often. Sometimes you get a paginate granuloma, which is some scar tissue growing around the peg. So there's a few more minor issues to deal with. I personally have not seen a major infection with the new titanium pegs, but that's always a concern. And often you get very dramatic movement. Here's a patient just showing how much movement you can get after the pegging procedures. And especially with my young patients, once they've had the pegging, they really don't want to go back to a non-pegged implant. But you can see how simple this system is. I just drill a hole into the implant and put one of these pegs in, and then I'm pretty much done. So it's a very straightforward procedure, and patients are often very satisfied with the results. Stephen, you want to make a few comments about the pegging procedure?
Yes. This isn't documented, but what I notice is when you peg the MedPore implant, it's usually flawless. And we haven't had any exposures with pegging, using the titanium peg on a MedPore implant. There are other cases that I've had where they use a titanium peg on the hydroxyapatite implant, and I've seen more exposures with that. And it's just interesting because some surgeons think that they can't use a titanium peg system unless it's with the HA implant, because that's the company that developed it. And you came right in and started using the titanium peg system on the MedPore implant, and it's working beautifully.
Greg, do you have comments?
I have the same thought that Steve has, that these pegs offer a big variety. And the variety, as we've already talked about, is better motility. The whole purpose for making these prosthetics is to make people back to normal. This is our goal. The patient has gone through so much to get to the point where they've come to us that bringing their appearance is the thing that they can hold on to and say, I've got control over this. The motility pegs do work well. There are complications, but just like anything else, anything that has any merit is going to last more than 5 years. And we talked about that with implants from back in the 60s, 70s, and 80s, the Iowa type implants, the mesh implants, the whole variety of different types of implants have come into play over these years. But I think in what we've got today with the motility implants, they do offer us a big variety of help. Lowered the laxity, less appearance issues. The thing that comes into play that we really need to specifically look at here on these implants is that we don't, at the University of Michigan, don't require these implants to be used as a primary first implant. When we're looking at the retinoblastoma world, or even some of the childhood injury ages, is that we would use those as a secondary implant when they're in their early teens. Typically 12, 13, and 14, where we're looking at more of a larger size orbit, and we're going back in and replacing these implants with the potential of having a peg put in. Not every prosthetic patient who has a MedPore or hydroxyapatite implant needs to have it pegged. It really comes back to the skills that Steve and I and our colleagues have in trying to offer them the very best motility with the least amount of risk. Everything that we do in our world is a risk-benefit ratio. How much risk am I willing to take for how much benefit could I ever possibly get? And when the risk is so high and the benefit is so low, then we start wondering, where do we want to manage our care? So we really look at how early on do we want to ever consider putting a MedPore or a porous implant in. And typically we don't ever want to do it early because we know we're going to have to change those implants later on. Not all patients need to have them replaced, but eventually they do.
That's a great point. I want to spend a few minutes talking about the two different categories of implants that we have. And as parents, you do have some input into what type of implant your child might receive. And I do want to spend a few minutes with our panel here talking about the two different types of implants. So the two big categories are the solid implants, and an example would be a silicone implant, and then the implant with the holes in it, we call them porous implants. And examples would be hydroxyapatite and MedPore. So what are the advantages and disadvantages of either one? The solid implants, or the older type of implant, they tend not to develop the exposure or the infectious problems as the porous implants. So the porous implants definitely have a higher chance of developing exposure and subsequent infection. Now, why is that? I don't think we know the answers to that completely, but it seems very important that the porous implants develop vascularization. It's really its purpose and the way it was designed. It was designed to allow blood vessels and fibrous tissue to grow into the implant. And when that doesn't happen because the implant's too big, there's not enough tissue over the anterior surface of the implant, exposures or erosion of the surface layer tends to occur. That may be, the increased risk of that might be due to the fact that the porous implants have a bit of a rough texture over the surface. They're not as smooth as the silicone implants. So implant exposure and infection is a major disadvantage of the porous implants. What's the advantage? The advantage that's been touted is increased cosmetic result, increased motility. Now, these porous implants do allow us to suture the muscles to the implant, and that seems to be a concept that the parents really like to hear, that we're suturing the muscles. I'm not sure how important that is long term because the tissues around the implant tend to all adhere to the implant with these porous implants, so I'm not sure if direct suturing is really all that important, but cosmetic result is supposed to be the big advantage of the porous implants. Now, that's never really been proven in a study per se. I have to say, in general, the porous implants maybe tend to look a little bit better, but the differences, if present, are pretty small. Now, one other major advantage of the porous implant is that they tend not to move around. So migration is much less likely with a porous implant versus a solid implant. I think the major issue that we have with solid implants, they don't get exposed very often, is that they tend to move around in the socket. Now, one of the major advantage of this solid implant was also mentioned by Greg in that if we're going to do an implant exchange later in life, it's much easier to exchange a silicone or solid implant versus a porous implant. So if you have a 2-month-old who's getting an enucleation, I probably would put a silicone implant in just because I know the 17 millimeter that I can get in at that time might be too small for them when they're 20 years old. So that's sort of my thinking on the two types of implants. What are your thoughts?
I think that porous implants are very stable, and I feel that they work very well if you can get a large enough size in it. And it's that same situation where if you have an infant and you're trying to get a porous implant in there, you're only going to get a small implant, and then someday we're going to want to take it out, and it'd be much easier to take out a solid implant. So there's that question: should there be a protocol where you always put in a silicone implant under a certain age, and then plan on a secondary surgery years down the road? That's a tough call. I have patients who did receive porous implants under the age of 1 and are 20 years old now and still have that 18 or 16 millimeter sphere, which is pretty small, but they're still doing pretty well and are reasonably happy with their appearance and are seeking no enhancements.
Great.
I agree with Stephen. I think when we start looking at implant selection, we need to look at the primary diagnosis. At no time do we ever want to put an implant in that's going to harbor, hide, or confuse us for deciding on what we're looking at. And you can imagine if we had a reoccurrence of an implant or a retinoblastoma or any other orbital tumor back into that orbit that's hidden inside of an implant that we can't see. So sometimes just the word diagnosis, early diagnosis, is maybe a selection that we may have to consider as a non-choice early on. Steve and I had an interesting talk. He's in California, I'm in Michigan, we talk quite often. We said, no one's really come to the American Society of Ocularists, the group of us that are nationally known, there's about 300 of us, and asked us if we lost our eye tomorrow, us Ocularists, what implant would we want? And Steve and I talked about that, and he said, and I asked him first, I didn't give him my answer until he answered, and we both agreed on the same thing. A porous implant later in life, not early on, anything past 12 or 15, would give us the best chance to have a normal looking appearance. Now, thinking of someone perhaps in their 90s, would that be an implant that would be of choice to him with potential side effects, pyogenic granulomas, infections, erosions, things of that nature? Probably not. We go back to this risk-benefit ratio. How much risk are we willing to take? If we have somebody in their young years, they have their whole life ahead of them that can benefit from this. Yes, there may be issues and maybe small things that have to come into play, but we can fix those. But give them the chance during the most important years of their life, the best chance to say, I've gotten past this and made themselves look better. And so Steve and I agreed. We said we'd have a MedPore implant with a titanium peg and have the best fitting prosthesis that we could possibly have. And I think we've come a long ways with that. But there's some risk. If I was 90 years old, I'd probably not take that choice. But if I was under the age of 20, up to 15 to 20 to 30 and on, I probably would consider that because of the benefits. The surgeons typically see the worst of the cases. They always come back. Steve and I see the best of cases that are already there working. If we had 100 patients and 10 of them went back to the surgeon and said, we had these as implants, they're going to be somewhat tainted by saying, every time I see a peg implant, we have a problem. Well, they never see the other 90% that he and I see every day in our office. And so we see the benefit. We see the long-lasting work that comes from that. We see the high school graduation pictures with the eyes looking in the right spot. We get the information that comes from the patient that says, this made a difference to me. And the unfortunate surgeons don't get a chance to see that because they never get to see the wonderful results. Typically, when they come from the surgeons to us, the ocularists are the ones who typically spend the most amount of hours, the most amount of days in front of the patient with their concerns and problems and their successes. And so as we kind of come across that idea, what implant would we have if our eye was lost tomorrow? We both agreed. Some sort of a PEG type of implant early on in life.
Brenda, what are your thoughts?
Yes, I'd like to show my slides.
Sure.
But what I will say is totally different. We might as well start with the slides, if we could do that. Yeah.
Could we have Dr. Galley's slides?
What I will talk about is a totally different way to take out to do what you call reconstruction only at the time you take out the eye. The enucleation is exactly the same, except we never put any sutures near the eye. When in our enucleation technique, we just drop the muscles and then we find them very easily after. But we don't put them onto the implant. When I was, and the reason we went away from the porous implants completely is because of the infection and extrusion rate and the long-term issues that you've described very well. In trying to deal with that, I went to India. In fact, I attended a meeting there and heard a beautiful presentation from Santosh Hanavar on the myoconjunctival technique, which is a totally different way to approach the surgery, the placing of the muscles, and the kind of implant. And the artificial eyes then are quite a different shape too. So while I don't have any slides, I'll stand up and show you what the difference is. There. So the traditional, this would be the implant, and the muscles are put onto the front of the porous implant, or even to a wrapping around the silicone implant, as you would say, the solid one you're referring to. And then those muscles, then you have the eyelashes, the space, and the muscles move like this, but as the artificial eye is sitting on top with conjunctiva between it, the muscles are moving the implant, and that rubs against the back of the eye unless you have a really perfect suction cup fit, when it works very well. Or if you put a peg in, then it won't rub either, and then they can move. The implants are very, very expensive. I don't know what an implant costs today, but it's $1,000 or something, depending on how fancy the company is that marketed it to you. The myoconjunctival implant puts in a marble. In fact, in some parts of the world, they go to the toy store and buy a marble. And there's nothing wrong with that. It's polymethyl methacrylate. It's not silicone. It is uninfectable. Nothing can get inside this object. And that's nothing but a space-occupying thing in the socket. So if now we have the marble is here, you close the conjunctiva, close the tenons in front of it, it's behind, it's way at the back of the socket, just occupying the space. So even in tiny babies, we get quite big ones, and we almost always get in 20 millimeters, which will serve the child for the rest of their life. And then, I wish I could have my slides. They're there. Could someone go and look at my slides?
Can I get your computer? We need your slides again. They can't get them up.
They are there. I saw them earlier. So the muscles do not go onto the implant. It just sits here. It doesn't move, it doesn't do anything except give volume to the orbit. And the muscles are fastened to the fornix. The 4 rectus muscles come into the fornix. So it's doing this. And so when the muscles move, it moves the whole purse holding the artificial eye. There's no rubbing between the eye and the posterior surface. And it works beautifully. That's the last slide of the series. Can we change? You have the changer. We go backwards to maybe? No, we're not. Okay, this is at the first. Or did it go back? So this was reported as a randomized, triple randomized control trial a long time ago. I think it's 2010. It received good attention in the developing world where you can't afford porous implants, and it's applied all over the world. It's the myoconjunctival technique, and the PMMA, this technique in comparison to porous implants or solid implants with the muscles imbricated to the front of the silicone implant or whatever it is wrapped. They were pretty similar in terms of no artificial eye in place and watching the movement of the conjunctiva, but as soon as you put an artificial eye in, the myoconjunctival was way better. The trick we do all of this, and we've done this for now maybe 10 years in Toronto. The trick is that getting the artificial eyes to fit, because the whole shape of the socket is very different than with the muscles imbricated on the front of the implant. And it needs to, prosthetic needs to go deep into the fornices because you want the muscles to be delicately holding the artificial eye, which is quite a narrow edge, and delicately moving it in every direction. Another movement advantage of this is not necessarily the full extension movement that you're talking with the peg, but there's micro movements. And micro movements make an eye look real. A prosthetic eye that's sitting here and the movements are happening of the muscles behind, but it's kind of rubbing before it grabs the eye. The micro movements here are very precise, so the eyes are never still, and so they look very real. So this is the appearance of one of these sockets where it's nice and white because you're looking, and if you put a flashlight there, it glows because it's a clear implant. It's large, as you can see. The artificial eyes tend to be, and are much best, quite triangular because there's a very large fornix at the top, which is created by the superior rectus muscle. And so the traditional eye is thicker, more detailed molding to the shape of how those muscles are attached. The myoconjunctival is very, very smooth, very kind of uniform. And actually, the person who's doing the fitting with us is very dedicated. He runs over to the hospital every time we need him in the OR to check something. And he doesn't just fit with putting the dental kind of stuff in to get the impression of the orbit. He works around the eye because then he can get the narrow edges and reaching deep into the superior fornix, which he can't do because the stuff you stick in through a syringe won't reach there. So you always have, instead of a nice thin artificial eye, you have a big fat one sitting here and it doesn't work well. The hardest part of all of this is to get the ocularist to recognize this as a different approach, and you need different shaped eyes. But the kids are great, and this is a whole bunch of kids with myoconjunctival approaches with their artificial eyes. There's no problem of weight on the lower lid, which is very common with the big, thick ones. These are very thin, they reach in, they hold, they almost hang off the top of the implant, and they're beautiful. And then I'll go back to what was I thought that was at the end. This is a child just a few weeks after her first custom myoconjunctival implant, and we've had no infections. It's no problem to take out the porous integrated implants. It's a bit messy to get it out, but once it's out, we find the muscles, we put them into the myoconjunctival position, put in the marble, and we're off to inject it. So it's totally different. The problem with getting this known is that it doesn't cost anything. The marble is really cheap. The whole surgery's faster, cleaner, everything's better about it and cheaper. So no one can make money, so no one will market it.
Well, those are some beautiful results. Stephen, do you have a presentation for us as well?
Yes, I have a short presentation if I may. Okay. Thank you for inviting me to speak. I appreciate it, board. I'm Steve Haddad. I'm in a private practice, ocularistry practice in Los Angeles, where I work alongside of 5 other board-certified ocularists. And Greg, thank you for coming down to speak with us today. So I want to give you a little better understanding of the thought process of an ocularist, and to help you understand how we try to make decisions in setting your prosthesis. So common ground here. One has been and one will be affected by the nuances of wearing an ocular prosthesis. And one has experienced all the concerns that we have discussed, and one will experience those concerns as he grows older. Our only hope is that we will have better techniques and advanced procedures to make a better world for the young baby that you see there. So what is the role of an ocularist? An ocularist should be providing you with the most complete and caring service, and to guide you and your child through the process of receiving a prosthetic eye at a pace that's comfortable for you and for your child. So in our initial consultation, we discuss the entire fitting process, what's going to take place, how we're going to make it, what we're going to do. We realize that by providing information, you make the patient much more comfortable. So many patients or children come in and they're very, very frightened and they're very hard to work with, and we don't have anesthesia. And so it's just what we have. So in some cases, it's just a consultation on the first visit and not much more is accomplished. But each time you come back, or each time the patient comes back, we accomplish a little bit more. And I think it's important to tell you that whether it's replacement prosthesis for your child or yourself, to give your ocularist the time that he or she needs to do the crafting. I don't know if this is an LA thing, but people come in, they sit down, I've never seen them before. They'll even, fly in from some other area and say, so when are we going to be done? I'll say, oh my God, I wish I was that good. So be patient and work with your ocularist and express your concerns. So as Dr. Galli was just talking about, there is another technique that I use very often. It's an empirical technique of fitting. So, and there are cases where an impression will not properly fill the socket, and the impression material will not find its way into the fornices, especially with a large implant where there's going to be a lot of front to back pressure and a thin prosthesis. The impression material will not make its way all the way into the socket. So sometimes I do both. And I compete with myself, and I'll take an impression, and then I'll start fitting empirically, and then I'll decide, okay, I'm going this road, or I'm going that road. And that's very effective. So once we do that, and we begin crafting our shape, I end up with a blank acrylic model with every patient that I fit. And, there are issues with every patient's eye socket. Very rarely do you get the perfect eye socket to work with. So in this case here, you'll see a retracted upper eyelid, and you say, oh, well, Steve, why don't you just thin that out and drop that lid? But that's not how it works. So what I had to actually do in this case is I actually had to create a thicker, So here I had to create a thicker upper flange. Oh, no, I'm just using the laser. I had to create a thicker upper flange to actually help to push this eyelid down and to try not to create too large an aperture. So after we fit the shape, we move on into the artwork, and there are different options for artwork. And of course, at this point in time, we only have two options. That's to either hand paint it or to use a digital printout iris. So we have done both in our office. The problem with the digital printouts is that it's really hard to get the monitor, the camera, the lenses, the printer to all agree and coordinate the perfect color. And also pupil size greatly affects the color of the printout. So we printed some digital irises and we ended up painting on top of them by hand, and then we found that our prostheses that we've always done by hand, just from start to finish, were really much more beautiful and very soft looking. So here's, a result of, this is an RB patient who is, she's about 14 years post-op, and so she does have a Med-Port implant, and it was obviously large enough to still look good. So she really has very little sulcus recession, good aperture, and I don't have her motility photos here, but her motility is probably average. I do agree with Dr. Galley that I don't notice a great difference in movement from a silicone to a porous implant if the technique used to implant the silicone implant facilitated a good position. So there are many points of judgment with an ocular prosthesis, and there are these little compromises that we make. And this is where it's important for you to actually communicate well with your ocularist, because sometimes the decisions we want to make you might not agree with. And then we also have the situation where I call it old eye syndrome, and somebody comes in with a prosthesis that's been, to make this easy, let's say has been looking in toward the nose, and they've been wearing it for 8 years, and I make the new prosthesis straight, and I know what they're going to say. They're going to say, oh, Stephen, this prosthesis looks way out, because they have accepted the way their prosthesis looks and their perception, and it's probably good that they're happy with their self-perception, but they're not comfortable with this new look, and it happens all the time. And we have a joke in our lab, and they'll come in the back, and an ocularist will say, I have old eye syndrome out there, please help me, But it's very real. And I had a man from France one time, and he had an enormous prosthesis, and I was so excited. I made this beautiful shape, and he looked at it, and he said, oh my God, this is terrible. It's way too small. I duplicated his old eye, and it was enormous, and he said, thank you so much, I'm much happier now. And I said, please don't tell anybody I made that. So in these points of judgment, there's a lot to be considered. And so let's say you don't have a good eyelid aperture, and the opening can't be what it is on the other side. So maybe we'll cheat on the iris size a little bit and make the iris a little bit smaller so that we can reveal more sclera. I think proportionate is what's important and natural. So the test that we give is I like to walk away from my patient when I'm done and go back in the exam room and just look first glance. And I ask myself the question is what's jumping out at me? Or no, nothing's jumping out at me. I love this. I'm happy. It's good. So these are the things. And so when you're evaluating yourself or your child, if you see something, say something. And your ocularist should either be able to make a correction or give you an answer as to why it is the way it is. So one of the things about large implants I wanted to say is that, especially at a young age, in infancy, it can be very difficult to obtain a good look. Because the prosthesis has to be so thin, and there's no vertex depth, or let's just call that the distance from the front surface to the back surface. If it has to be really thin, we can't manipulate the front curve of the prosthesis. So oftentimes with an infant, if we have a really large implant, I have this sort of flat shape because I'm trying to keep the projection back. And if I use the front curve that we need, there would be too much projection. So communication is important to really explain to the parents that this implant may not be desirable at this point in time, but 3 years down the road, we're going to have a lot more room to work with, and we'll have a much better result. So it's also important to know that the first prosthesis or two are very temporary, and that things usually get better in time until years down the road. And Greg, I'm going to let you come in and talk about that. This just shows you how pupil size can affect the look of a prosthesis. So the pupil's off here, and it sort of throws everything off. And that's because she's in a very bright room in our office. And this little baby is here today. And this is David. He's a few months old, and he's 10 weeks post-op. And again, no issues with sulcus recession or anything like that. It's too soon to have those problems. And same thing there. Greg.
Good morning, and thank you for the opportunity to speak with you today. I would like to thank the Education Committee and Steve Haddad and Dr. Kim for the opportunity to come here and speak a little bit about what Steve and I have pretty much given our entire career on. And I just found out we both started 38 years ago doing this, so we have 76 years of experience between the two of us on what we talk about. As Stephen has worked on the early years, I'm going to do some of the later years of what to expect, what to be involved with, and see what we can come up with for some success. These are, again, the 2 years post-op, and you can see Stephen has done a wonderful job. I will also disclose that these photos are courtesy of Stephen and his daughter Sarah from their office, and they do a beautiful job, so I'm kind of piggybacking on some of their slides here. Again, some 8-year results, wonderful positioning of lid heights, beautiful gaze, no lower lid laxity. Again, 8 years post-op, have done very well. Eyelid ptosis, we see that sometimes with these large implants, and sometimes even early on when we do a primary enucleation, if we get too big of an implant, it doesn't leave enough room for the ocularist to really produce a good prosthesis because of the issues of volume. And so we need to have some room in there to maintain the prosthesis fit and hopefully best motility. We both agree the bigger the better, the earlier on as we can, because not every patient who gets into the early teen years ever needs to have an enucleation, or needs to have a secondary implant. If it comes down to the point where we as ocularists are having troubles managing the prosthetic care and the fit and the appearance, it can be related to too small of an implant. So that's where we talk about these secondary implants. And we typically would never want to put a porous implant in as an early on type of an implant, just because of the potential of having to remove it and how difficult it is and how much scarring there comes into play. Also keep in mind that if Steve and I have both been in this long enough to know early years of radiation, external beam radiation, and how much damage that caused to the lids, the sockets, the lacrimal system, the fornices, the conjunctiva muscles. All of those are hopefully behind us now with plaque radiation. Those have given us a lot less destruction within the orbit, but we still have a lot of involvement with these sockets. Patients who've gone through multiple surgeries have some conjunctival scarring issues, have muscle atrophy, they have socket atrophies and muscle involvement. So we really come into a position where these sockets are kind of individualized as we move along from childhood all the way up through adulthood. So the porous implants have their place. I would not say they're perfect for everybody, but they're part of the tools that we all have to look at. Increased superior sulcus, again, as the child grows, it's like growing out of shoes. They're going to grow out of their prosthesis and potentially their implants. Droopy orbits, again, everything begins to shift and change. As we all know, gravity is not very kind to us, so it has a tendency to pull things down. We get lower lid laxities just by the weight of the prosthesis and the volume of the socket at times. Less motility, and we've talked about that. Here's another patient that has a wonderful result. Again, 14 years later, beautiful result, great position. And they have an appearance with them that if you didn't have that picture on the left, you could not assume that this patient had a prosthesis on the right or on the left side. The best compliment Steve and I ever get is that nobody knows that they had a prosthesis. And we work so hard, so nobody knows how hard we worked to get them to this point. And that's the best thing that we get out of our involvement with the patient is nobody knows what had been done to them in the past. Even to the point when they've gone into physicians' offices and they try to dilate the other eye is even the best thing. But yes, somebody even in the ocular field thinks that it's still real. It can become a problem for some patients in the ER. I had a patient who got in a car accident, went to the ER, and they thought she had a brain tumor or brain involvement, and found out the prosthesis was on the one side, and they couldn't get. The patient was also in a coma from the accident, and within a couple of days, they realized that this was a prosthesis and not a brain injury. 20 years later, again, survivor, retinoblastoma, no secondary implant, and no surgical procedures, and it was still a beautiful result. And again, it's what you are able to accomplish with what you've got, and be able to use the tools you have to get to the result where something like this looks as good as it can possibly be. 22 years later, no cosmetic results. Sometimes we talk about ptosis corrections, lower lid laxity corrections, all kinds of small minor procedures, fillers, injections, things of that nature. We can do pretty well, but as time goes on, the world of aging gets to us, and that's where some of these motility pegs come into play, where they help keep the weight off the lower lid, no matter how thin or how light you make the prosthesis. Orbital implants, again, we start talking about them, and this is kind of what we look at here. There's a small implant, larger implant. We start talking about levator functions, and we start talking about superior sulcus, which is this area up here. This kind of corresponds with this loss of involvement here. Now, this is an older gentleman with a lot of years, and you can start seeing a lot of atrophy loss up here, ptosis, and then we start correcting the prosthesis, or with the prosthesis. We try not to do any more surgery than we absolutely have to. We can add an extension up here, pull on the levator, and start raising these lids up so we can get a nice appearance. The loss of orbital volume up here is a big problem for us because if we try to fill it, we increase more weight. If we increase more weight, we have more lower lid laxity, more sag. So we're very protective about how many procedures we do on these patients because we don't, it's kind of like baseball, 3 strikes and you're out. You try to do this, you try to do that, and before you know it, you've used up some of your surgical stuff early on in their life, and all of a sudden as they get later, it becomes more of a difficult problem. So we try to, our very best to try to keep things light, small, and get it positioned. If we can get it to work with the prosthesis, then that's even better yet. Nobody wants to put their hand up first and says, let's go do surgery first. And that's Steve in our profession is trying to manipulate the prosthesis to the very nth degree so the patient doesn't have to go through any more surgeries. Sometimes with patients with implants that we have extruded implants, and sometimes the patients won't go back and have a secondary implant right away. We start getting into some problems with the fitting of the prosthesis because there's no volume back there to give the prosthesis support. So you got a loss of volume here. The pressure of the upper eyelid being pushed back here will start tilting this back, starting to shorten the inferior fornix, and you'll get a rotation problem here. Secondary implants are typically what we like. Sometimes that's not possible, so dermis fat grafts become a secondary or third option for that. Again, don't underestimate gravity. Gravity is very not kind to us. It's on us all the time, and it's constantly pulling down. Also with the function of the eyelid. If you want to do the math, we open and close our eyes every 6 or 7 seconds, 18 hours a day, and you do that for a lifetime. How many millions of times have you pulled down across that lid? And the weight of the lid is laying on that prosthesis. The function is pushing it down, so you're constantly pulling down on these lower lids and causing irritation. So that becomes a concern. Briefly, we'll talk about some motility implants. This is a patient who has a motility implant. We're talking about this kind of motility. Left, right, up and down. This gets to be very natural. It's in that realm of cosmetic balance. It's in the realm that these patients look just as good as anybody else. If it has a loss of movement maybe to one side, it may look like a lazy eye. And everybody has an Uncle Chuck or an Uncle Betty that has a lazy eye that may not turn one way or another, but it becomes socially acceptable instead of having an eye that just gets fixed. So the motility pegs and a great fitting prosthesis over a porous or a non-porous prosthesis or implant works very well if you can get it to work. Here's what the pegs look like. Again, we've already talked about that a little bit of redness in this photograph, but this is a titanium peg. Here's a motility peg, also in an acrylic form. And we talked about the noise, dislodging of the peg in and out of the holes, rotations. Early on, when we started doing these back in, it was, I think the very first hydroxyapatite implant came out in November of 1989. And I had my hands on those implants 2 years before that at the university, and we had some rotation issues, and we had some concerns early on, and we were able to work around some of those as years went on. Again, difficulty with noise, patient management, and frequent visits to the ocularist. Care. Oops, let's back up. When we start talking about cleaning of prosthetics and how we handle that, we really want to be cautious about what kind of products we use. Now, I have no financial interest in any of these products. These are just things that we particularly use. One is the gas permeable contact lens stuff, because it's also working over acrylics. Johnson's baby shampoo is a very mild type cleaner, great for the hair so it doesn't irritate the eyes. And also the one I use the most is Dawn dish soap. Very high detergent, inexpensive, readily available, and it rinses off well. It does everything we would like it to do. Different kinds of lubricants. We have artificial tears. Typically, most of the ones you buy over the counter are water-based lubricants. There are silicone artificial tears that work very well. There's some natural ones that are mineral oils, and there's some ointments that work very well. You got to remember that these only work if you put them in the right place. It's like putting oil in your car. You say, I got it in the trunk, but I didn't get it to the engine. If you don't put the drops or the ointments underneath the upper eyelid, which is where our lacrimal system starts, it's not going to be very effective. You got to put it up here first. Remember, the oil's got to go from the trunk to the engine before it ever works. So keeping the drops underneath, even to the point of tilting them back. For patients who are visually impaired, they can put them on Q-tips or even on the clean finger and get them up underneath the lid. We don't like putting drops and things from our dropper onto our eye, but for some patients, it's the only way to work. They can take the bottle that they get from the store or from the Ocularist for the oils and actually put it on the prosthesis, lift up the eyelid, tilt the head back, give it a squirt, wipe the tip off, and go from there. That's another way to make sure it gets to the place. The other thing they can do is also when you put the drops in, put your finger right by your nose here and hold it there for 10 seconds. All right? 10 seconds. You've done all the work to get it to there. Why get it running down the drain or running down your nose and the lacrimal system if you could just put your finger there, keep your head back for 10 seconds or 15 seconds, and get the absorption of that even better. So that's another way to manage what you've got. The other thing we really, really have to talk about is eye protection. Eye protection is the ultimate help to maintaining the health of the other eye. We try to start with the kids at the age of 2 when they start walking and beginning to be mobile, is you want to get them on some protective glasses. There's all kinds of varieties of glasses out there. Some are more cute than others. Some are more expensive than others. So you have to let your dollars and your guides help you with that. If a child does not like their glasses, they will not wear them. They'll wear them on their face to the bus, and then they'll take them off and go from there. If they don't, they're going to put them in their bag and go from there. Also, cosmetic optics that we can put in the glasses. You can make things look bigger or smaller by just changing the glasses. Every pair of glasses need to be polycarbonate, high impact resistant, and that manages the other health, the protection. The last thing I want to talk about, and this is probably the most important thing for you to get out of my talk, is the American Society of Ocularists. This is the group of us nationally. There's about 300 of us, and we have an organization that it's hard to find us. In the state of Michigan, there's only 4 board-certified ocularists in all of the state of Michigan. And that's 8 million people, and there's only 4 of us. So it's 1 of us for 2 million people. So if you're going to look to find an ocularist any place in the world, because we have patients from all over the world that need help, is they're going to go to www.ocularist.org and find an ocularist. Look under the tab, and you'll find an ocularist there. And you can get their credentials, you get their ideas, who they are, and be able to get some help. Thank you.
Well, thanks so much. I'd like to really thank my panel for their contributions, and I'm being told we don't have time for questions.
Sorry, I'm mean. If I don't get you guys to lunch, you'll all be mad at me. So please save your questions for the panel for lunch. Okay, we're all going to be sitting together, so that'll be a good time for it. And I've got our next panel coming up already, who's run by our session leader from Houston, Patty Chavez Barrios. Thank you guys very much.